and welcome to the Journal of the American Society of Echocardiography podcast. My name is Dr. Johri, and it's my pleasure to present an article from the August 2021 issue of the journal as part of this special summer series for the journal. It's also my great pleasure to have two guests today. I'm very excited to have Dr. Federico Asch today, as well as Nick Grubic, who has helped with JASE Podcast in the past. So welcome, everyone.
Thank you, Amr, for the invitation.
Thank you, Dr. Johri.
Thanks, Federico and Nick. So today we're going to be presenting echo correlates of in-hospital death in patients with acute COVID-19 infection from the World Alliance Societies of Echo, or the WASE-COVID-19 study. So before we get started, Federico, it's very nice to have you on board today. Can you tell me a little bit about what's new and exciting happening in your part of the world?
What is exciting? Well, I think 1 week ago it was exciting that everything was opening and we were all starting to feel much nicer, but I'm happy to say that at least I had some time to go on vacation. Spend some time on the beach, refresh a little bit, and ready to work more on WASE and many other projects that I am.
That's great. So you had a chance to do a bit of traveling?
I did. I've been actually to Croatia, which is where my wife is from. We had a really good time, family time there. Okay,
that's wonderful. Yeah, I've heard the coast is beautiful there. So yeah, speaking of traveling, the last time we had you on our podcast, we were both at Echo Hawaii.
That is correct.
Yeah, so it's a bit of a golden era, pre-pandemic golden era, and I'm hoping that things will open up again and we can see each other in person again.
Hopefully so, yeah.
Yes. And what's also interesting is that the podcast, which is available in our archives, was related to your right ventricular free wall strain paper, as I recall, and its ability to be predictive for pulmonary hypertension. So it was a nice paper that you had summarized for us. So that's also available in the archives if our listeners are interested. So what we're going to do is talk about the paper today. And what we're going to do is get Nick to start by presenting a short summary of the paper. So Nick, why don't you take it away?
Perfect.
And while Nick sets up, just before he begins, Dr. Asch, I was wondering whether you could give us a few words with respect to what WASE is. I think the majority of our Echo audience is familiar and have heard of the World Alliance Societies of Echo, but it would be nice to refresh our memory with respect to this large program that's been going on for several years. Certainly, I've been hearing about it for the last few years.
Absolutely. WASE is a collaborative approach, an international collaborative approach of investigators from around the world that we are using as a platform to be able to investigate specific topics that may not be as easy to investigate on a single institution or in a single country. This has been led by Dr. Roberto Lang at the University of Chicago and myself at MedStar Health, always with the support of the American Society of Echo, and particularly important with support from industry. So it's a program that we actually are using as a ways of fostering collaboration among investigators, with the society, and with industry to be able to answer specific questions. You are all familiar with the normal values studies, and in this second iteration of our program, we are investigating COVID.
Great. Yes, I remember, I believe this program started during the presidency of Dr. Lang, if that's correct, and you were instrumental in getting it started as well. What was the motivation for you to start this program, which would require a lot of effort to begin?
Yeah, this actually started a few years after Roberto's presidency. It started actually as an initiative that came up while we were doing one of the ASC humanitarian missions, and Roberto and I got to interact a lot during that trip, and came out of a very simple question, and that one is, I actually approached Roberto and I said, Roberto, you just published these guidelines on chamber quantification and you're proposing all these normal values. But what I see is that you are basing those normal values as reference values only coming from studies that were conducted in the US or Europe. Do you think these values would apply to people living in other areas of the world or from different ethnicities? So from there, we started, brainstorming on how we could address it, and we both were very involved with international initiatives of the American Society of Echo. So we felt that this was actually a good opportunity to bring together brains from all over the world and get a project going, a meaningful project going from the ASC. So we got support from ASC. We got multiple investigators for the first study. We enrolled patients in 19 different countries, and it was a very successful project that we are still publishing. Very often we have at least 10 publications from that, and I think we're learning a lot about what normal values are, even with more novel technologies such as 3D and strain. So when COVID came, and we had already all these relationships with the international investigators, we felt that there was a need for an urgent understanding of what the phenotypes of people having acute COVID infection would be. And we thought there was no better opportunity for us than to try to gather again many of these investigators to enroll patients and do a scientifically valuable evaluation of patients with COVID. And that's how the WASE-COVID study started, which obviously started as soon as the pandemic started, actually.
That's amazing. Amazing effort. And just the last bit of context that I'd like you to provide, can you speak at a high level with respect to either racial, geographic, or genetic differences with respect to chamber quantification? Can you sort of give us an overview of some of that very briefly?
Yes, of course I can, and I will do it very briefly. If I have to summarize it, is by saying we are clearly identifying that people coming from different areas in the world and from different races have differences in the size of the left ventricle, the left atrium, and so we are doing a very extensive analysis on the WASE study with all 4 chambers, with novel measurements and so, and we are proving indeed that when we talk about normal values, it's too easy to take it as one set of reference values. We do believe that there is a need for actually adjusting not just to gender or age, if you want, but also to adjust for the regional or the race, if you want, of the patients, right, and the region of the world they come from.
That's great. Great context for this paper. So with that context, why don't we take it away? Nick, why don't you present us this iteration of the WASE-COVID study?
Yeah, that sounds great, Dr. Johri. And thanks, Dr. Asch, for really providing that context. I was really excited to sort of see this paper because you can really see how large of a sort of a global effort and a global collaboration it was to conduct this study. And I think that's really what we need when we're thinking of COVID now, whether it's sort of vaccine rollout or looking at sort of echocardiographic parameters. It's really nice to see these regional differences that you sort of highlighted. So I'm just going to give a brief overview of the article today, and As Dr. Johri mentioned, this article can be found in the August issue of JASE. So this study presents the preliminary findings of a large multi-site study known as the International World Alliance Societies of Echocardiography, or WASE COVID-19 study. And the overarching aims of this study was to identify echo parameters that would be prognostic of clinical outcomes in patients with COVID-19, as well as understand geographic variation in COVID-19 cardiovascular outcomes. And specifically, the objective of this preliminary report of the WASE-COVID study was to describe the clinical characteristics and echo phenotype of acute cardiac disease in patients with COVID-19 infection, and to explore their in-hospital prognostic value. So this was a retrospective study of all adult patients with a diagnosis of COVID-19 who were enrolled in 13 medical centers in 4 world regions, so specifically in Asia, Europe, the United States, and Latin America. And all patients were enrolled during the initial wave of the pandemic. So this was from January to September 2020. All clinical information and cardiac ultrasound images were collected from medical records, PACS systems, or echo machines. And all of this information was de-identified and then transferred via a web-based system for central analysis. And the authors of this study used sort of 2 unique techniques for image analysis. So all LV analysis was performed actually through artificial intelligence algorithms, which were created by machine learning. And then RV analysis was performed through clinically available software. In terms of the statistical analysis for this study, the primary outcome was in-hospital mortality, and the authors developed univariate and multivariate binomial regression models to identify clinical and echocardiographic parameters associated with in-hospital mortality. So overall, there was 870 COVID-19 positive patients that were included in this study. And all patients were recruited from various different centers in 9 countries. And the distribution of enrolled cases over the 9-month period did actually differ across the 4 global regions, beginning mainly in Asia and then followed by Europe, the United States, and Latin America in chronological order. And regional differences, as Dr. Asch mentioned previously, were quite apparent in the global patient groups. So compared to those enrolled in the United States, Latin America, and Europe, patients enrolled in Asia seem to have fewer heart and lung disease-related comorbidities. And then similarly, there was better functional values for LV and RV parameters that were observed in Asia in comparison to the other global regions. And for the overall patient cohort, in-hospital mortality was just over 20%. And globally, Asia and Europe had the lowest rates of in-hospital mortality at 10.8% and 19% respectively, whereas both Latin America and the United States had poorer rates, both over 25%. And in the multivariate analysis, the parameters that were significantly associated with in-hospital mortality were age, previous lung disease, left ventricular longitudinal strain, lactate, dehydrogenous, and right ventricular free wall strain. So overall, this study confirms the profound effect of COVID-19 on the cardiovascular system and was also the first to highlight significant regional differences in both cardiac phenotype and echo utilization. And as the authors mentioned in the paper, future studies will aim to determine whether cardiac involvement in COVID-19 has changed over time since the initial months of the pandemic.
Great. Thank you very much, Nick, for that summary. And so I'm just going to ask Dr. Asch a couple of questions so that he can get into it in a little bit more depth. One of the questions I had was with respect to the AI parameters. And I really liked the fact that this was one of the largest international studies using AI techniques. But the paper, it's not an AI paper, so we don't really see exactly what the algorithms are. But Dr. Asch, can you tell us a little bit about that? Like how did you come up with these methods? Who were you collaborating with? And I know you're not an AI specialist in terms of being a computer programmer or anything, but maybe you can tell us what you understand is different with respect to the AI versus the automated, semi-automated techniques that we already have.
Yeah, those are great questions. And if I overlook some aspect of your question, please ask it again, because I am not too good on tracking them. So how did we come up with this? Well, listen, we knew that a trial like this one would take a long time to enroll patients, to analyze data, to process all the echoes and so on. So we sat and we said, how can we get this on a timely manner that would be relevant to the clinical community? Maybe if we take 2 years, in 2 years, hopefully COVID is history, and whatever we find means nothing. So for us, a way of getting this done quickly was by exploring AI technologies that could provide an automated, fully automated analysis. And that was really the motivation for us to reach out to different industry partners that we knew of and see what they could offer to achieve this goal. And that's how the AI comes into the picture. Specifically, we ended up selecting one company to work in this project, although there were others that were very, very relevant and could have done it as well. The reason why we selected this one, first of all, is they had an absolute commitment to the academic part of this. So they wanted to do it. They wanted to do it as part of their own research and development, but to provide a service to the community. So, which was something that we had in common. So we had a mission in common, and that's why we selected this company. This is a company that is called Ultromics. It's based in Oxford, in England, and is a company that had an FDA-approved algorithm that was used specifically for left ventricular function in stress test settings, for stress echoes. So we said, okay, if it can measure ejection fraction and strain in a complicated clinical situation, such as the patient exercising or just after an exercise, maybe it can deal with suboptimal images that we know we are going to get, because no one wants to spend too much time with the patient that has a COVID, right? So we knew the image quality was going to be a limitation. So we partnered with them. They provided a service that basically including de-identifying the images, uploading them to the web, transfer them to a core lab, and in the process of being transferred, the images would be subject to the AI algorithms, and then provide already an ejection fraction and a left ventricular longitudinal strain. That's all that the system could do, the AI system could do, because we wanted to, on one hand, also evaluate right ventricular function. Then we had to use other systems for the RV, because Ultromics could not provide that. And at the same time, although it was FDA approved, we wanted to make sure that what Ultromics was measuring was actually accurate in this specific setting. So what we did is, in addition to having the AI measurements, we got every single echo read by a board-certified echocardiographer as well. We had a pool of 7 echocardiographers that were randomly assigned echoes in a way that every echo would be read by the machine as an automated, and then by 2 blinded to each other echocardiographers. So the numbers that you see in the paper is actually the average of the 3 measurements. And we do report they are inter-observer, intra-observer, machine observer, variability, and so, which was very good. And the RV, though, was all measured with a semi-automated system. So that's really where AI comes from and how we got to do that. And we're happy to report that it was a big success. It worked as we planned to work.
That's great. It sounds like you had some great partnership there, and I'm sure there was a lot of effort with respect to problem solving and technical difficulties, that troubleshooting. So kudos to your group for getting that done in such a rapid manner. We're still in the pandemic, and it's amazing that we've got this paper out. So speaking of which, one of the key findings for me, which was a nice, interesting and surprising finding, was the value of RV free wall strain, which I always like hearing about from you. You've taught me quite a bit about that in the past from listening to you about this parameter. So can you tell us, do you also agree that that seems to be one of the key parameters? And then what is the implication of that, the clinical implication of that?
So yes, I do agree with you. Right ventricular free wall strain as well as left ventricular longitudinal strain, both were independent predictors of in-hospital mortality. So that's how relevant, clinically relevant, those two values are. Yeah. So and by the way, this was not the first report to find that. I mean, there's a study that came from New York that published before us on the value of the right ventricular strain, specifically in patients admitted with COVID-19. So it is a strong finding. It's a very important one. It shows that it is independent from other clinical factors, and that's how relevant we believe it is.
Yeah, and I noticed within your authorship group, Dr. Z from Wuhan was also involved, and I know that group has also published with respect to the importance of RV strain. I've had the opportunity to collaborate with them as well, so I'm familiar with some of their work.
Yeah, they were the first one, by the way. Then it came a larger series from New York, but they were the first ones to report.
Yeah, that's right. So that brings us to, I guess, one of the limitations. So how hard is it to do RV free wall strain? Does this mean that if we're doing echoes in patients that are COVID-19, our protocol should include RV free wall strain? Is that sort of what echo labs and sonographers should walk away with, perhaps?
Well, so I would say yes, but I think one important point to mention here is that the acquisition protocol was left to each of the centers. So each center would do the acquisition protocol that they would consider needed. In that setting, we could measure the right ventricular strain in over 65% of the patients. So, I mean, it's not that difficult, and considering that the acquisition was not with RV in mind, we still could get reliable numbers in over 65% of the patients. So it's doable. I think it should be done. It has significant value, and it could even be better, because if you do RV focused views on every single patient, probably your yield is going to be higher than 65%.
Right, and so reminding us of the RV focused view that's showing the largest diameter of the right ventricle. So it's not your typical 4-chamber, but it's adjusted to show the maximal diameter of the right ventricle as per the ASC guidelines for the RV heart.
Indeed, and basically you have to put the RV in the center of the image. So if you're missing part of the LV, that's fine. You're really focusing on the RV.
Okay.
Sorry,
great.
If you're missing part of the LV. Sorry.
That's right. Yep, that's really interesting. And so the other thing I noticed was that although you found RV and LV longitudinal strain to be independent predictors, the AUC, or the area under the curve, while being good, wasn't excellent. And so that was a limitation. And you mentioned that that means that you can't necessarily hang your hat on one parameter, like we say for all of our echo parameters, right? So can you tell us about that and integration with other parameters? What does that mean?
Yeah, it means exactly what you very well interpreted, Amar. It's these are parameters that have a prognostic value. They are not perfect. They are far from being perfect. But when you put them together with other variables that are also predictive, clearly helps identify patients at higher risk. When we say higher risk, doesn't mean that the patient is going to die. It just means it's going to have a higher risk of dying. But that's exactly what this means. I don't think I have much more than what you said.
Okay, perfect, great. So we're not going to go through this paper comprehensively. There may be a webinar in your future that ASC may call you up to talk about this paper in a more thorough manner. And the purpose of the JASE podcast is to get our listeners excited about the paper, so they download it and look at the graphics themselves. So I just wanted to make sure I didn't miss any main points from the paper. And let Nick present any questions that he may have. So I just wanted to make sure, Dr. Asch, was there anything else you wanted to mention about takeaways from this paper?
No, I think Nick had a great presentation, very clear, probably more clear than what I could do it. And then the questions afterwards, I think, dig a little bit deeper. So I'm very happy with the messages we're conveying.
Okay. And Nick, did you have any last questions?
Yeah, I just actually had one question for Dr. Asch, because I noted sort of reading this article that I guess this was sort of the preliminary report. What is sort of the next steps for the COVID WASE study? Like, what is the group interested in looking at next?
Yeah, I don't think it's preliminary. It's actually final, but it's one part of the study because it's all the in-hospital outcomes. We did follow up on these patients for an average of 230 days. So results of that are going to be published. We did another, in a subgroup of the patients, we did a second echo. So changes in, or if you want left ventricular and right ventricular remodeling after the admission, it's also something that will be coming along. It's a paper that is under review right now. And then we did a very exhaustive comparison of the AI analysis versus the human analysis, which was presented at the ACC scientific sessions, and the paper is close to being submitted. So it's at least we're thinking of those 3 papers, right? Yeah. But the investigation itself has been finalized. So patients have been followed up for what we expect it to be, and that is an average of 230 days.
Great. Yeah, definitely interested to read those papers once they're published. So looking forward to that for sure.
Thanks, Nick. So that's great. We look forward to more work from your group, Dr. Asch. And I really wanted to thank you for your time at the end of your day. I know you're a super busy guy, so I really appreciate that. And I'd also recall that you are a photographer, and I'm very interested in learning about our guests that we bring to their podcasts and what they do in terms of their spare time sometimes. So tell us about your photography hobby. And my question for you is, can you tell us a photographer or a photo we should all Google after this that you think would inspire us or is a favorite of yours?
Well, there's many. I am an old-fashioned photographer. I started doing photography before digital cameras were available. So I used to have my own dark room in my bathroom.
So you did your own film processing and stuff.
Yeah, okay. That's what I used to do. So if you ask me about my favorite photographers, are those classics from the early 20th century. The first one that comes to my mind is Henri Cartier-Bresson, who is a French photographer that specialized in social photography.
How do you spell that last name?
Cartier, it's like the watches, Cartier, and the second part is Bresson, Bresson.
Okay.
You can probably pronounce that in French much better than I can do.
No, that was good. Yes.
So that's one of my favorite photographers, and because what I like is social photography. Taking pictures of people in the street, and that's you may be familiar with some of my pictures from the different ASC humanitarian missions that I participated in.
Yes, I remember you presenting that at a talk at one point. Yes.
Yeah. So I enjoy a lot taking pictures of people and portraits and situations, and that's
capturing their personality and speaking through your lens.
Exactly, and getting to know people with my camera. Yep.
That's wonderful. Well, thank you very much for sharing with us, Dr. Asch. And I'd like to remind our listeners that Dr. Asch's paper, along with his many colleagues, important colleagues on this paper, is available in the August 2021 issue of the journal. So I'd like to thank everyone for joining us today on this weekly JASE podcast, and I look forward to presenting another paper next week. So thanks, Nick. Thanks, Federico. I appreciate it.
Thank you both.
Thanks.